Thanks for listening to the Pharmacy Podcast Network.
This is the Sex PharmD podcast with your host, Dr. Nadia Archambault, licensed clinical pharmacist and certified sex therapist. With a focus on women's sexual health and wellness, Dr. A is here to cover important health topics and answer all of your questions about subjects that can be applied to pharmacy practice. And now, here's Dr. A.
Hello and welcome back to another episode of Sex PharmD on Pharmacy Podcast Network. Today, I have Dr. Dana Gibbs. She is a board-certified ear, nose, and throat physician turned integrative medicine hormone specialist. Welcome to the show.
Hi, thank you very much for inviting me. This is really exciting.
So the first question that I think a lot of people are going to ask, and myself included, is what does an ENT care about hormones?
Yeah, that is actually a very good question. It takes a tiny bit of time to answer that because, I'll give you the long story short thing is, the first part of it is that I had low thyroid starting from probably when I was a teenager, at least then, or maybe even earlier than then. And it never got diagnosed and it never got recognized all through the end of high school, college, med school, residency. And, part of that is just that doctors aren't really trained on the details of what Hashimoto's or hypothyroidism looks like. But the other part of it is that my TSH wasn't ever abnormal. And what happened was I was at an allergy conference. So ENT is ear, nose, throat. So we do sinus disease and allergies and all that stuff. And I was at an allergy conference. And this is after I was out and had a solo private practice. And I had figured out, sinus surgery by itself doesn't fix everybody. So I got to go learn how to do allergy. And it's part of the board certification of ENT anyway. It's just something that if you don't go and focus and get extra training on it, it's mostly something that ENTs will ignore unless they have sought out that extra training. But I was at this training course and I had already heard one of the lectures. And so I wandered into the other room. When you go to CE, a lot of times there's 2 or 3 rooms going at once. And I wandered into the other room and they were talking about hormones and low thyroid. And as the guy went through the list of symptoms for hypothyroidism, I realized that I had that. He listed the, being cold all the time, the exhaustion, the waking up with night sweats, the, difficulty sleeping, but feeling like you need to sleep literally all the time, the brain fog, all the stuff. He said it. And when it was listed out there, it was like, I couldn't unsee that. My life was completely changed by that list. He also said 2 things that kind of shocked me because I thought everybody with hypothyroidism was overweight, which is not true. Right. And he said, not everybody with hypothyroidism has an abnormal TSH. And I didn't realize that could be a thing either. And so when I went back home and went back to my doctor and said, hey, I'd like to try taking thyroid medicine. And what I was given at first was Armour Thyroid. Mm-hmm. And it was like this miraculous, holy cow, what is this? Is this what normal people feel like? Wow. And I couldn't unsee it. I could not unsee that list. And so as patients would come through the ENT clinic, I would notice, I was like, oh, well, you've got, lumps in your neck. You've got the loss of your eyebrow hair on the sides. You've got thin hair up on top. You've got this list of symptoms. You don't sleep well, all the things. And I couldn't unsee it. And one of the things that hypothyroidism does is it really kind of suppresses and damages your immune system to the point that you get sinus infections all the time. Who knew, right? So, or asthma or whatever, just, very frequent upper respiratory infections. And that's what people come to me for, is frequent upper respiratory infections, sinus, et cetera. And also for thyroid nodules. Those were two things that are in the standard realm of ENT that I would see literally every week. I would see somebody or other with one of those or more than one of those things. And I would go, well, you have hypothyroidism. And they'd say, well, my doctor said my TSH was fine. And I'm like, yeah, I know, but, we're going to retest it and we're going to do it this way. And the funny thing was, it's like, so I'll use an example. This one woman came in, she was in her, mid-30s. She was a school teacher. It was winter. She had a horrible sinus infection and she'd had it for months. And I was like, well, your CT scan is terrible. You need sinus surgery. And she's like, well, I have to wait until summer. I'm a school teacher. I can't take that time off. So I said, okay, that's fine. Mm-hmm. And meanwhile, do you mind if we try some stuff for your thyroid? And she was like, yeah, sure, let's do it. And I saw her again 6 months later and school was fixing to start again. And I was like, well, when are we going to do your sinus surgery? And she's like, oh, no, I'm not here for that. I don't need that anymore. I'm all fine. I just need a refill on that thyroid medicine you gave me. And it was just like, wow, mind blown. I'm on to something here. Mm-hmm. Maybe, and so my journey continued, my continuing education, started being almost all towards hormones and towards what's going on with these people. And I was like, oh, you know what? I can stop somebody with a thyroid nodule. I can stop it from growing so they don't have to have surgery. Let's spend more time looking at that. How does that work? So there was just this impetus towards not only fixing my own self, but all these patients that came pouring through that had stuff. And I'm like, who's taking care of this for you? Nobody. Oh, they told me it was fine. Oh, they gave me this levothyroxine and it didn't help me feel any better. They said it's fine, but I don't feel any better. So, the more times I heard that, the more I was like, I got to figure this out. And the more people I helped, the more reputation I got. And the more reputation I got, the more people I helped. And so it just became this circle of, wow, this is really a thing. So when I got ready to stop doing surgery, my eyesight changed. I got, neck pain, and I'm like, I don't want to look through a microscope all day, every day anymore. I want to do something else. So this was kind of the natural next step, because half my patients were already hormone patients anyway. So here we are.
That's amazing. I would have never think to make that connection that people with thyroid issues are coming in with sinus issues, urine ENT, the nodules. Yeah, I would have never thought of that at all. And I actually did not know either that you did not, the TSH levels may not be abnormal. I didn't even realize.
Yeah. So we can go into that more if we have time. So there's a couple of things that happen, and one of them is stress. And stress, comes from so many different avenues. I mean, stress comes from malnutrition. It comes from autoimmune disease. It comes from, mental stress. It comes from over-exercising. It comes from, childhood trauma, anxiety, all these things. There's so many different things. And your body perceives that stress the same. and it reacts the same. I mean, it has two weapons. It has adrenaline and it has cortisol, and that's all it has. Like, the carpenter, the old saw about, when all you've got is a hammer, everything looks like a nail. Well, your stress system in your body is very, very primitive. It has those two hormones, and that's all. But when those are activated constantly, there's a couple of effects that happen. And one of them is that it pushes down on TSH. It's like your body says, oh, we're starving. We got to cut TSH off so that we don't burn up all our calories, burn up all our resources. We got to survive the winter.
Mm-hmm.
We got to survive the famine. We got to survive the winter. And so it's a funny thing, because guess what happens when you diet? Your body says, oh my gosh, it's a famine. We have to survive. So it turns down your TSH. So you go in and they say, oh, no, your TSH is fine. Well, did they check your hormone levels? Maybe not. Did they check your T3? Maybe not. So that's one way that it does it, is it does it directly by turning down TSH. That's stress. The second thing that happens is that there's a fine control knob on thyroid function in your body, and that's something called reverse T3. And reverse T3 is like the sister product of T4. T4 is how thyroid hormone comes out of your thyroid gland for the most part. And it goes around to your body cells, and your body cell says either we need more of this, let's turn it into T3, or we're full right now, let's make it into reverse T3. And reverse T3 is a very, very similar molecule, and it can actually, and this is controversial, I will tell you that, it can bind the thyroid receptor in the nucleus of the cell and block it. And so if you have a lot of reverse T3, your body is saying, hey, you know what? We got too much, we got to block it. And so you can have a normal TSH, a normal free T3, a normal free T4. And if your reverse T3 is high, you will still not get thyroid function. And it could be for a reason like you're taking your thyroxine medicine for your hypothyroidism one time a day, and the levels are fluctuating from, the studies that have been done, and there's not a lot of them, have shown that the level when you take the thyroid medicine, the pharmacokinetics, it's like it goes up and then it goes down, and they say, oh, well, the half-life's 2 weeks. But truthfully, it can vary as much as 30% over the course of a day when you're absorbing it from your GI tract before it's bound into the binding proteins or whatever. So that fluctuation at the high end turns on that reverse T3. And once it's on, it takes a while for that to wash back out of your system. So that's a second way that your thyroid function can be not normal, even though your thyroid hormone numbers look normal.
Very interesting. And I'm sure, like yourself, like so many people are misdiagnosed or just not diagnosed because of that.
Not diagnosed, yeah. Or they're given levothyroxine and it doesn't make them feel better for those exact reasons.
Yes. I know a lot of pharmacists listen to, these podcasts on Pharmacy Podcast Network. And I know as a pharmacist myself, it's always been so incredibly challenging when we have patients just getting that dose right with the
yes.
or like a brand name versus a generic, and they switch it, and it's unbelievable. And I've worked in compounding pharmacy where it's a little bit better because you can tweak it a little more, but it's probably challenging things to regulate, I feel. And mostly I've seen it in women.
Yes.
It's
unbelievable. Probably 80-90% women.
Yeah.
It is. Yeah. So there's a couple of things that I recommend that folks do. I was going to save them for your top 3 at the end, but there's a couple of things that I recommend folks do if they're having trouble getting regulated on their thyroid hormone. And we can talk about that now, or we can save it.
Yeah, let's do it now.
Okay, let's do it now. Okay, so the first thing is I really encourage people to break their levothyroxine pill, whether it's a generic, whether it's Synthroid, whether, Tyrosint you can't break, it's a capsule. But any of the other ones, you can break them in half. And I encourage folks to take them twice a day to just try to take the top and the bottom off of that wave, that sine wave that you get when you only take it once a day. So the low is a little bit higher, the high is a little bit lower. And so it doesn't stimulate that reverse T3 quite as much. And I have seen a lot of people, and this is something I have everybody do when they first come into my practice. I say, you know what? We need to get some new labs, but I'd like to get them in this specific way. So break your pill in half, take it twice a day for the next 2 weeks, and then we'll get your labs.
I like that. That's a really good. Yeah.
It's funny because, and I looked into the history of Synthroid a little bit. And when Synthroid was first manufactured, it was marketed as a once-a-day med as a convenience because the current way of doing natural thyroid, which was all there was before Synthroid came out, was 2 to 3 times a day. And people were like, well, I don't like that. And so it was like, oh, here's a med we can take once a day because the half-life is so long. Well, guess what? They didn't actually do. They didn't actually do any pharmacokinetic studies. They didn't actually do them.
That's crazy. Yeah.
and so, the fellow that's my mentor and me have both basically kind of done experiments with our patients, not experimentation, but it's like, okay, Mrs. Jones, what time did you go to the lab? Well, you went at 4 p.m. Well, your number looks really low compared to the last time when you went at 10. And what you see if you test the same person over and over again is you get a wave, you get a high and you get a low. And it's not a 2-week half-life like they're saying when you take it as a pill. Maybe what comes out of your thyroid gland bound to binding globulins is, but what you take as a pill varies maybe 30%. I mean, it's a pretty big variation.
Yeah.
So that's thing number one is take it twice a day. Second thing is go to the lab at the same time every day for the exact same reason, because when you take it, and what most doctors are having people do, or most specialists are having people do, is take your thyroid medicine today, go to the lab as early as you can tomorrow. But that could be 25 hours. It could be 28 hours. It could be, I don't know. So what I have them do is I'm like, okay, take your med at the same time every morning, write down what time that was, and go to the lab 6 hours after that. And then take your evening dose at the same time the night before. So you wouldn't ordinarily take your evening half of your medicine at 6:30, but the night before you get your test, that's how you do it.
Yeah.
And the reason you don't take it at 6:30 is because at 9 you would like to be sleepy so you can go to bed.
Yeah,
so,
that makes sense.
so what I tell people to do is pop the pill in your mouth right as you're falling asleep, and that way you'll be wide awake in the morning instead of at the very nadir of when, it's like, that's never made a lot of sense to me. It's like you want a lot of energy in the morning, so you wake up at the very lowest point in your thyroid dosing. It makes no sense to me. It's like, okay, if you have some on board when it's time to wake up, then you wake up a whole lot easier than you do if it's been 24 hours since you took your last dose of med. But anyway, so the twice a day dosing, and then take your labs in the middle of the day. And that's no matter what kind of thyroid medicine you're taking. And it works really, really well.
That's great. This is a lot of valuable information. Absolutely. Now, the reason why I wanted to have, you talk about this is because I've, met patients, seen patients who have low sex drive because of thyroid. It affects so much, it can affect mood, how you're feeling, your energy levels.
Yes.
So as far as that goes, I want to talk also about your actual practice consultants in metabolism.
Sure.
have you seen patients who have come to you also with low sex drive issues, or, is there anything specific that you talk to them about for that?
Okay. So you would be a little bit surprised, maybe, I don't know, but a substantial portion of the people that I see are there for infertility, either either recurrent loss of their pregnancy or the inability to get pregnant in the first place. Almost all of them have extremely irregular periods. And some of them have no periods at all and have been told they're menopausal. They've been told they have early menopause. And it's just amazing what happens when you get their thyroid rebalanced where it's correct. And then their periods come back and they're like, oh, this is interesting. And, even while I was still in ENT, I helped 2 ladies get pregnant just by doing that.
Wow.
And they had been told their thyroid was fine. And so
it's amazing.
Yeah, absolutely. Absolutely. Improper thyroid balance really messes with the signaling of sex hormones. I don't know how much detail you guys go into, but it messes with GnRH. It messes with the LH surge. It messes with the levels of estrogen, progesterone in your body. And it messes with sex hormone binding globulin as well.
Oh, see, that's interesting. Yeah. I mean, that's definitely something that would, affect someone's sex drive in general.
Yeah.
Yeah. And the fertility thing is huge. I've been talking with women about fertility and incorporating it on my Sex PharmD show also, because it's about a lot. And now there's a lot more options with IVF and things like that.
Yes.
But if your hormone's not balanced, it does make it harder.
Yeah.
Yeah. Yeah. And a lot of women, I don't think, a lot of times they'll say, all right, let's check this, let's check that on the labs and the hormones. And for thyroid, I think is so important.
Yeah. Thyroid is a little bit tricky because you can have every single lab number technically be in the normal range and still be out of balance.
That's so crazy.
I know.
Yeah, it's so crazy. And I know I've met some women who have had Hashimoto's, but it took so long for them to get diagnosed with it. I mean, just in general. What do you see a lot of with that? And I guess if you want to explain Hashimoto's for some people that don't know
what it is. Sure.
Yeah.
Okay. So Hashimoto's is one of a set of 2 different autoimmune diseases that affects the thyroid gland as the main target of that autoimmune disease. And Hashimoto's is actually the most common autoimmune disease. And what it can do as it's attacking the thyroid gland is that it causes damage, and then it can release a whole lot of hormone. It starts the hormone being released from your thyroid gland in an irregular fashion. Instead of, steady and nice throughout the whole day, it's up and down, which is why people with Hashimoto's disease will come in with such high levels of reverse T3 because of that up, down. Your body reacts very strongly and harshly to high levels of thyroid hormone to knock those down because they can be deadly.
Yeah.
Your body doesn't tolerate high thyroid hormone levels. So Hashimoto's disease attacks and damages the thyroid gland, and it doesn't do it in a nice, smooth, steady way. It does it like, okay, it attacks and then it backs off and it waits, and then the antibody levels kind of fade out, and then some stressors or some illness happens, and boom, it activates it again, and then it's attacking, and little by little it damages the thyroid hormone more and more and more until it not only is the reverse T3 high, but now it can't even keep up and make the normal amount of thyroid hormone anymore. And when you start getting really serious into the symptoms with, and some people will say, 40 pounds of weight gain, they're just exhausted. Their hair all falls out. I mean, some people have a really dramatic, holy cow, what the heck is wrong with me kind of a reaction. But if you were to go back in their timeline, if you had some way to go back in time and see that those thyroid antibodies might have been there since they were 6, 7, 8, 10 years old. They might have been there a really, really long time. So it's two separate diseases. So you've got the autoimmune disease that's attacking your gland, and then you've got the thyroid levels that are as a result of that. But you still have to, people are like, oh, I want to cure my Hashimoto's disease. And I'm like, well, yeah, we can work on that. There's lots of lifestyle interventions. There's, diet and proper nutrition and supplements and things that you can do to calm down that antibody reaction. But, at the end of the day, if your thyroid gland can't keep up anymore, then you still have to supplement with thyroid hormone. And, not everybody wants to hear that. They're like, oh, I want something natural. Well, I want something bioidentical. And, we can argue all day about bioidentical, I guess, but there's no fake thyroid hormone the way there's fake sex hormones.
Yeah.
You know what I mean? Yeah. It's like if your body needs thyroxine, it needs thyroxine. If it needs liothyronine, it needs liothyronine. And you can either get it through a synthetic product, which is identical to what your body has in it in the first place, or you can get it from an animal product, which is identical to what your body has in it in the first place. Now, the proportions may not be the same, but the molecules are the same. And there's no, there's no birth control pills for your thyroid. There's no fake chemicals that you can use and expect them to do something to help your thyroid metabolism. It just doesn't exist.
Yeah.
Thank goodness.
I know. Yeah. And then there's the overactive, you know.
Yeah, and that can exist within the Hashimoto's spectrum because of the fact that the damage can cause the thyroid gland to release a whole lot of thyroid hormone all at once, which is why so many people with Hashimoto's have that high reverse T3. But over time and gradually, it'll go down and down and down.
Yeah.
Unless it just fades away. Now, 50% of people who have Hashimoto's disease diagnosed, their antibodies go away and everything goes back to normal, and their thyroid gland goes, oh, I can still keep up, and they're fine without doing anything. That happens about 50% of the time. There is one other autoimmune thyroid disease, and that's Graves' disease. And what happens in Graves' disease is that the antibodies, instead of attacking and damaging the thyroid gland, they attach and they stimulate the thyroid gland as if they were TSH, as if they were thyroid stimulating hormone coming from the brain, only it's not coming from the brain, it's coming from your immune system. And it pushes the thyroid hormone levels in your body higher and higher and higher until you go into a crisis where your heart beats too fast and you're losing weight rapidly. And you can get very, very sick from that. You can die from that pretty quickly, which is why I think that we have reverse T3 is to try to damp down that high thyroid reaction and basically save you from your own immune system.
Yeah. I mean, yeah, I know that one can be very dangerous for sure.
It can be. It can be.
Yeah. Yeah, that's good. That's like a good refresher for the pharmacists listening and for anyone that didn't know about that. That's a very valuable information also. Moving to your consultants in metabolism practice, I love that you're doing this. You're looking, you have a way to balance hormones And it's a real holistic approach. If you
Yeah.
could elaborate more for that on that, that would be awesome.
Sure. So what I found as I was teaching myself or getting educated, I didn't teach myself most of this stuff. I learned it from other doctors, was that thyroid doesn't exist in a vacuum. Your thyroid is only one hormone system in an entire system of hormones, your endocrine system, and it's your adrenal glands, and it's your sex hormones, and it's your pancreas, and it's your leptin and your melatonin, and there's so many hormones. And I mean, now they say even vitamin D is a hormone, which I believe because of all the stuff that it does in your body.
Yeah.
And you cannot mess with one of those things without affecting something else. It's funny. I was listening to one of your earlier episodes, and you were talking about GLP-1 inhibitors and how people can all of a sudden accidentally get pregnant because they did something that changed their insulin. And it's like, oh, well, you change your insulin, it changes your sex hormones, it changes, it's just, there's no way to just do one of those things.
Mm-hmm.
And that's actually a big beef that I have with a lot of people who treat hormones, because the gynecologists don't understand insulin sensitivity, and the endocrinologists only understand this one little part of thyroid. They don't understand the nodules and the autoimmune disease and all the other stuff. And there doesn't seem to be one specialty that says, okay, I want all of it. I want to learn it all. I want to do it all, because you can't do one without the other. And so that's what I do. And what I find is that I end up treating a lot of people with chronic fatigue syndrome. I treat people with PCOS. I treat people with infertility, as we discussed.
Mm-hmm.
A lot of people with kind of chronic pain syndromes. And it's you kind of have to go in a stepwise fashion, because thyroid is important, but your adrenal glands are kind of like the orchestra, the conductor of the orchestra. And if you don't pay attention to the adrenal glands and you fix somebody's thyroid, then all of a sudden they're so rubbed up that they can't stand it. They won't tolerate the medications. And it's just like, okay, what do you do with that person? Well, you've got to use some mind-body medicine. They've got to meditate. They've got to calm their stress response down. They've got to adequately nourish their adrenal glands to the point that they can produce as much as they need to be producing. Because if you don't do that, what you get is your stress response is all adrenaline all the time, and that's fight or flight. And that becomes this horrible spiral of, I can't rest, I can't sleep, which makes the stress worse, which, I mean, it's just awful. It increases the chronic pain, and chronic pain causes more stress. And it's a horrible spiral that some people cannot get out of on their own, just with healthy nutrition and meditation and the like, even if they have the energy to do that, which most of them don't. Yeah, they don't. So that's where I generally will start is, okay, I get all these labs, but I'm looking for that history. I'm looking for that trauma history. I'm looking for that, okay, how does this person manage their stress, handle their stress, and helping them get back into a more healthy stress management pattern. That's kind of thing number one. Supplementing their adrenals so that they're not overreacting, but they're also not suppressing. I mean, when you suppress the adrenals, you suppress the thyroid and the sex hormones right along with it. There's no way to just suppress cortisol. It doesn't work. Yeah. I see a lot of people using what they call adaptogens. Ashwagandha is a big one. And I don't love that. I mean, I'm going to call it's an herbal drug. It's a drug.
It
And
is.
we don't know all the stuff that it does, but one of the things that it does is it pushes down on cortisol production. And that may be nice, but your adrenal does more than cortisol. Your adrenal gland makes the precursors for all the sex hormones. Your adrenal gland, when it's suppressed, it also suppresses your thyroid. So you have to take into consideration all that stuff
Yeah.
when you're treating somebody. So once I've got the person with the adrenal support that they need, and then the thyroid more optimized, then we start working on their diet. Once they've got the energy to get up in the morning and cook a healthy breakfast, then we, it's like, okay, now let's work on your diet, because insulin resistance is, it feeds back. When the more insulin you have in your body, the worse your cortisol is.
Mm-hmm.
You can't ignore that. You have to do things to change how you eat. And so then once we've got all that, and then we work on the sex hormones, and it's like, okay, getting your insulin back under control allowed your estradiol and your progesterone to be more in balance. And so sometimes that's all it takes. Sometimes they don't need to go in, but there's perimenopause, and perimenopause is, oh my gosh, I feel I've been through it already. Thank goodness I'm done with that. But I feel for any woman who's there, because one, the mainstream medicine still doesn't believe you. You go in there and you say, "Doc, I'm having palpitations," or "I can't sleep," or I'm sweating through my sheets at night, or whatever it is. And not only are the overlap of those symptoms with hypothyroidism or with thyroid fluctuations, they're about 70% overlap. Hello. But then you've also got the fact that if you're still cycling, it goes up and down and up and down. And it's like, oh my gosh, you've got anovulatory cycles, and then you've got heavy bleeding, and then you've got, okay, now you're anemic because you've been bleeding so much. And so then I got to fix the anemia before I go on to the other stuff. And it's just like, if you don't have the whole forest in mind and just focus on one tree, you're not going to get the patient. You're not going to get the patient better.
I like that.
Their numbers may look better, but they aren't going to feel better.
No,
they're not going to start losing weight. They're not going to accomplish their goals.
Right.
Yeah.
Yeah. It's just like putting a Band-Aid on something, but you're not fixing the whole problem. It really. Yeah. Now, with people, what have you seen as far as that with what you're doing? I've talked about that also, because it affects a lot of women. And as far as what are you recommending for treatment also? So
PCOS, the first thing you have to understand about PCOS is that PCOS comes from insulin resistance. And insulin resistance is, sometimes it's a genetic thing. Sometimes it's triggered by stress, because stress causes high insulin, which causes high cortisol, which causes even higher insulin. So sometimes it's just stress. Sometimes it comes on in perimenopause. When you start losing your estrogen, that's another thing that triggers high insulin levels. But anyway, you can be 25 years old and have your blood sugars be perfect and still be insulin resistant. That's been proven in a lot of studies recently, where they can put sedentary people in a room, give them an oral glucose tolerance test, and watch their sugar just do the normal thing. But if you also check the insulin, their insulin will be twice as high as the non-insulin resistant people. That was done. I'm thinking that was at Yale where that study was done. And so it's like, okay, so the first thing you have to do is manage the insulin resistance. It's not something that's just going to go away. It's not something you can just take a pill for, although there are, like metformin helps some, maybe 10, 20%, but it's the right kind of exercise and the right kind of diet. I mean, so you need, what I call it is a low insulinemic diet. So there's a
Okay.
low glycemic diet, and that's like for type 1 diabetics, so their blood sugars don't go up and down. But a low insulinemic is like, yes, you can have carbs, but they're slow carbs, and you eat your protein first, because what you're looking for is to avoid that insulin spike.
Okay.
And
Yeah.
the lower your total insulin goes, the better things get with regards to your PCOS, because it allows your LH surge to come back. And you know, and so I guess we should stop for a second and just say what PCOS is.
Yeah.
So because of the high insulin levels, you have high LH all the time. And when you have high LH all the time, then when your cycle goes through where it's supposed to ovulate, you don't get the LH surge, or you don't get a high enough LH surge to actually allow the ovarian follicle to rupture and release the egg. And when the egg doesn't get released, you don't get a corpus luteum, so you don't get progesterone. And when you don't have progesterone, then there's nothing to stop the bleeding, and it just keeps going.
Yeah.
And you have infertility, and the corpus luteum that isn't there. There's no modulating effect on something called theca cells, which are inside the ovary, and they start making testosterone, and they start making dihydrotestosterone through an enzyme called 5-alpha reductase. And I'm getting too deep in the weeds here for you guys.
No, that's okay.
But 5-alpha reductase is an enzyme that turns testosterone into dihydrotestosterone. It also turns progesterone into allopregnanolone, which is responsible for the migraines and the PMS and the PMDD that people get. But dihydrotestosterone causes the chin hair and the acne on your back and on your chest, and the weight gain, and a lot of the things that are not good within PCOS. So there's two things you can do. The first one is get those insulin levels down by whatever means you can, which is, exercise, and, don't eat starchy carbs, basically. Don't eat, really don't eat sugar, but don't eat starchy carbs. And then the second thing is to take a 5-alpha reductase blocker. And there's a great herbal 5-alpha reductase blocker called saw palmetto. And I give that to people pretty frequently. Now, if you want to get pregnant, you better not take that. You cannot. I mean, it messes up the fetus, because the fetus needs dihydrotestosterone. And if the fetus doesn't have it, there's going to be genetic defects. And
I wonder how many people know that.
I don't know. But that's something I always really, really precaution people. I'm like, look, if you are ready to get pregnant, you have to stop this herb. And if you're not ready to get pregnant, then you have to use something else to stop pregnancy, because when we fix your PCOS, you are going to have higher fertility.
Yes.
So, boy.
Huh. Wow. Yeah. That's there's so much more to it than just hand the person a birth control pill. Right.
Oh my gosh.
I get so aggravated when I see a patient, my first question is, when was your last doctor's appointment, OBGYN appointment? When were your last labs done? That's like always number one. Like, when was all of that done? And then what medications are you on? And it's so aggravating when they're just handed something like that, and there's so many other things going on.
Right. No, it's absolutely true. It's like, well, okay. I mean, I realize that's what the GYNs are taught to do.
Yeah.
But there's so many better ways to take care of PCOS. Of course, they require the cooperation of the patient, and they have to actually change what they eat.
Yeah, that's huge.
And they have to exercise.
Yep.
So
the whole lifestyle. So when you're seeing patients, so let's say someone were to, they're on, I love your website, the Consultants in Metabolism. I love how you have the courses, you have like the little, you have the blog, the
Yeah.
hormones for online classes. That's all fantastic. Are people able to schedule telehealth calls, or how does that work?
Yes. So right now my practice is Texas.
Okay.
And I have a medical license in Iowa as well, so I could see people there, and be your doctor. I have
Okay.
a few folks who, if they have a really good relationship with their doctor, then I can consult with them and help them figure out, okay, you need to try this next. We need to do these labs, and then make a suggestion about prescribing. If it's if it's necessary for them to be on a prescription, then I wouldn't necessarily be able to prescribe in their state. But
Yeah.
yeah, I do 95% of my practice is virtual via telehealth.
That's great. It's so much more convenient for people too. I know COVID
Sure.
changed the world, which has been great for people, and usually they're more
Yeah.
comfortable too talking about things. I
Mhm.
find that's
Yeah.
great.
Well, yeah. I mean, and when people come in, it's important that they understand that this is not a quick fix. It's not just me handing you a pill. This
Hmm.
is going to be, I don't want to say it's a slog, because I was talking about that, changing the time of day of your thyroid medicine. I've had a couple people recently come back and text me 2 days later. Oh my gosh, I feel so much better. What did you do? And I'm like, what did you do? And they're like, oh, I just changed when I took my medicine. I'm like, boom,
Amazing.
it works.
That's
and
amazing.
it goes in steps like that. For some people, it's like a slot machine. Put a nickel in, you put another nickel in, you put another nickel in, and all of a sudden, boom! Now all the the happiness is pouring out. And for other people, it's like, you know what? You get a little bit more and a little bit more and a little bit more. And it frustrates me when some people are like, after step one, and they're like, oh, I feel so much better. I don't need to do the rest. And I'm like, really?
You have to do everything.
I know you don't want to do all the rest of it, but you don't even know how bad you feel until you don't feel that way anymore.
It's true.
That's what's so frustrating to me, is there are so many people out there that have been tired for their entire life and don't have any idea that they could feel different.
Yeah.
And and that's one of the things about the Hashimoto's patients, is a lot of them felt fine for a while and then they didn't. So they know something's wrong, and they remember what it was like to feel good. People like me, I mean, I started feeling bad almost before I can remember. And so when I didn't anymore, it was just like,
Yeah.
wow, this is what normal people feel like. It was
And
amazing.
that's so sad. I mean, it's so sad that you had to live like that for so long too, where you're like, wow,
Yeah, it
this
was
is
almost 20 years. Yeah.
Unbelievable.
Yeah, it was hard.
No, I think it's wonderful that you're working with, people who are going through menopause, perimenopause, postmenopause, thyroid. I mean, it's a whole list of different disorders and things that happen, and a lot, unfortunately, affects women. So
Yeah,
I think
it is, like I said, 80-90% women in my practice.
yeah, no, that's amazing. So if you want to share how, so I'll put in the show notes, the website, everything that, as far as we can share if you have Instagram, Facebook, things like that. It looks
Yes.
thyroid too. A podcast, Beyond the Thyroid. Also.
Yes. So I started a new podcast just a few weeks ago. It's called Beyond the Thyroid. I'm very, very excited about it. It's going to be a little bit sciencey, but it's one of the things that frustrates me. Before I started that, I listened to a lot of other podcasts that were about thyroid. And one of the things that frustrates me the most is when they oversimplify something and they make it sound like it's easy, and it isn't.
Yeah.
And so I was just like, look, people are smart. If they want to listen to somebody else oversimplify it, that's them. I'm cool with it. I try to use plain speech as much as I can. I try to explain things with analogies as much as I can. But yeah, I'm going to start. I start from the beginning, and I told my story in a lot of detail. And then I started in on, okay, what's your thyroid for? What does it do in your body? What can go wrong with it? And then one by one, we're going to go through all the thyroid diseases and then all these other related hormone diseases.
I love that. And you have like every single platform, including TikTok. And thank you for being on TikTok, because we need more professionals on there giving professional advice versus I've seen.
Oh my gosh, don't get me started.
Yeah, like all about what is happening right now. Oh, that's frustrating. But this is great. You're on every platform. Yeah. And I've so much. I mean, this is why I love doing this podcast too. I always learn something new. But we learn about thyroid in pharmacy school, and unless you're really, dealing with it a lot, like I dealt with it with compounding pharmacy, but there's that's being developed now with that, and it affects everything, and and obviously, hormones and everything also. So fantastic. So if someone wants to get in touch with you, what's the best way? Should they go on your website, email, or?
Yes. So the best way to get a hold of me is to go on my website and set up a discovery call. There's a button on the main page.
Okay.
It says, schedule a discovery call now, and go on there and set something up, and we'll chat for a few minutes. And if it sounds like what I offer is something that sounds good to you, and I'm pretty sure I can help you, then we'll go from there.
Right. That's awesome.
So that's how I do it. And my website is danagibbsmd.com. That's pretty simple.
Yeah, and I'll include it in the show notes too. No, it's been really, really eye-opening having you on. I've learned a lot. I'm sure our listeners have learned a lot also. And I appreciate everything that you're doing, especially because, this affects mostly women. So that's something I'm really passionate about also. So
yeah.
Thank you so much. And thank you so much for coming on.
Thank you for having me. This has been really a lot of fun and wonderful. And I can't wait to listen to more of your episodes, because I found them very, 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 very medically accurate. And I was just like, oh, thank goodness. and informative, like your Wegovy chat just a couple of weeks ago. That one was wonderful.
Oh, thank you so much. That means a lot.
All right.
Thank you so much.
You're welcome.
Bye.